Am I audible? Am I clear? My voice is clear. Just somebody raise your hands. Fine. So somebody has responded. Thank you very much. So this is the second part of the introduction. So last time we saw about how to calculate the rate, rhythm, and axis. So hope you have practiced the rate, rhythm, and axis. Whenever there is a ECG in the group, please try and do the homework in such a way that attempt for the rate, rhythm, and axis. That is the bottom line. Once you start attempting, possibly you will start learning much faster. So these are all very basics, and a lot of people might be knowing it, and some of the people who are in the beginning of their career definitely can go through this. So moving on to the next. So the template, how I am going to teach, I told you, ECG, rate, rhythm, and axis. Now today we'll see P wave, PR interval, QRS complex. So these three we will see today. So P wave, you can see here, I am using the laser pointer and showing here. So P wave is just the beginning, whatever I am showing here, to the end of the upright wave, and to the end of it is the P wave. PR interval is the beginning of the P wave to the beginning of the QRS complex is the PR interval. And the QRS complex is the beginning of whatever may be there. It is Q, then it is QRS complex. If it is first wave is R, then it's also QRS complex to the end of S wave. So that is QRS complex. So we will see all these things today. So these are all something which I repeatedly give this picture for understanding the basics. Simple thing. From SA node, the impulses are conducted through three different pathways in the atria into the AV node, and it innervates the atrium completely. And AV node acts as a speed breaker. So there is a stagnation in the impulse. This speed breaker is for the only reason atrial electrical activity. Following the electrical activity, there is a mechanical activity. That is, atrium contracts. Once the atrium contracts and opens the blood open the mitral valve and tricuspid valve, the blood reaches the left ventricle. So this transient period of electrical activity into mechanical activity and filling of the ventricle from the atrium, you require a few seconds. This is exactly somewhere around 100 milliseconds this is happening. This 100 millisecond is sufficient enough for the atrium to contract and eject the blood into the ventricle, and these ventricles are filling. That point, after that, the ventricle has to get innervated. So that is the reason there is a specialized conduction system. So after the filling of the ventricle will be innervated, and following the innervation, ventricle contraction, that is depolarization, takes place. Right? You should understand this depolarization taking place. Right? So this atrial contraction, whatever the atrial innervation, electrical activity out of the atrial innervation is the P wave. From the SA node starting to the completion of the AV node and into the QRS complex, until this place is the PR interval. After this place, you have the conduction into the ventricle, and the ventricle is contracting. Depolarization is happening. This is what is the QRS complex. The QRS relaxation, repolarization will be there in the STT waves. Right? You understand how the PQRST is formed. P wave is only the atrial electrical activity. PR is atrial electric activity and the AV nodal speed breaker. So once it crosses, the ventricle is filled, and it is ventricle requires some electrical activation. This is given by the bundle of his right bundle, left bundle, and this gives electrical activity throughout the ventricle, and this will cause contraction of the mechanical contraction of the ventricle and ejection of blood. This is the electrical activity given to the ventricle is the QRS complex. Right? Having understood the basic, we will see further. See here the same thing from the SA node to the AV node. It takes 0.07 seconds to the max. Right? So this is what is the duration of the P wave. Now you know what is duration of P wave will be only maximum of 2 millimeter or width of 2 millimeter. Now you understand why I am saying 1.5 to 2 millimeter. 0.07 seconds is only 70 milliseconds. You know, every small square is 40 milliseconds. So less than 2 milliseconds small square, height and width. This is represented by the 0.07. From this impulse to this area is less than 2 small squares, right? This is what is happened. Now you see 0.16. So it means that 4 small squares. I told you every small square is 40 millisecond. Every 5 big squares, the small square makes a big square in the ECG. This will be 200 milliseconds. So from this area to this area, it takes only 0.16 is 160 milliseconds. It means PR interval usually between 120 to 200 milliseconds between 4 and 5 small squares. Now you understand from this picture what is P wave, how much is the duration of P wave, how much is the duration of PR interval. The 2 points are very clear. Duration of P wave and duration of. See here, from this area to this area is P wave. From this area, after the speed breaker is PR interval. After that is the QRS complex. Now you understand the basic. So again, I come back to the basic. See, this basic class is very, very important for the only reason whenever the electric current always is positive when it currents is passes towards electrode. Electrode is nothing but whatever you place the ECG leads in the chest means the current is coming from the inside the heart towards the electrode is positive. Suppose the AVR is in the right upper limb. You saw in the axis. It is like a torch light. இப்போ ஏவிஆர்லேருந்து பார்க்குறப்ப டார்ச் லைட் அடிச்சு பார்க்குற மாதிரி ஹார்ட்டை பார்க்குற மாதிரி யூ ஜஸ்ட் இமேஜின் யூ ஆர் த்ரோயிங் எ டார்ச் லைட் அண்ட் சீயிங் த ஹார்ட் seeing the electrical activity of the heart. So the torch light from the AVR, you are seeing it from the right upper limb. The heart is there. So any electrical activity away from the heart, away from the AVR will always be negative. So AVR is in the right upper limb. So away from the heart is SA node is in the top. And it conducts from top to bottom. So all electrical activity in AVR will be negative for that reason. So anything which is happening in the down apex, V5, V6, it will always be positive because all the electrical activity is conducted from the SA node to the apex. So it will always be positive. Now you understand why electrical current conducted towards the electrode is positive, away from the electrode is negative. 2 points you have got. Now, more closer the electrode, more sensitive is the electrode for QRS complex. It means you are placing right on the heart means your ECG will be very tall. Whereas it is away from the heart means ECG will not be tall. Now you know why QRS complex in V1 to V6 is much taller and the limb leads are much smaller. Because this lead all electrical activity is directly recorded over the chest. It is much taller because it is very sensitive. Current பக்கத்திலே இருக்கனால it is very sensitive. That's as simple as that. So from there, from the heart, the current reaches the peripheral electrode, augmented leads and the limb leads. It is not closer to the heart. It is away. So that is the reason why you will not get very tall QRS complex like the chest leads. So now 2 points are clear. Towards the electrode is positive because next points I am going to tell are all based on this. Away from the electrode is negative. QRS complex, when it is just the electrodes are placed very close to the electrical activity, it is very tall. Away from the electrical activity, it is very small. Now you will understand why I am saying this. So having known that, again I will come back. When I will say sinusoidal, that is the SA node is being the prime pacemaker. Every P wave is followed by a QRS complex. Now every P wave is followed by a QRS complex. Now, next point is PP interval is fixed. So the next expected P wave falls on the exact location of in the ECG. P wave is upright in lead 1. So now you understand lead 1 is in the 0 degree. You are having the SA node in close to AVR. That is the right upper limb. So from right upper limb to left upper limb, the ECG current is flowing. So it means P wave will always be upright in BYR, lead 1. Whereas P wave will always be inverted in AVR because it is away from AVR. Now, this is the reason why every ECG, you look all these things, and if it is there, you call it as sinus rhythm. So this is what last class we are seeing. Now again, I'm repeating for benefit of everybody, and also you will also understand that this is how it is happening. So what will happen next? P wave, present or absent. That is one thing. So in every QRS complex, you have to look at preceded by a P wave. If it is present, then we'll analyze the P wave. If it is absent, we'll think for why it is absent. That's all. If it is present, we'll analyze by whether it is regularly present or not. Sinus is the mirka. Then the contour, whether it is wide or high or tall, what is there, it is normal or abnormal. This is what we have to see. We'll see. See here. Now I will come back to the basic. Whenever there is a electrical activity towards the electrode is taller, positive, and very close to the electrode is taller. 2 points. Away from the electrode is negative. Far away from the electrical activity is smaller. 2 points. That's all. Now I will tell you atrium from here to this area, from SA node to AV node, from top to bottom. That is, it is coming down. So your 2,3 AVF is an inferior lead. So by in the diagram wise, see here, this is AVF. This is lead 2. Because this is the inferior axis. See, you are seeing all these things in the inferior axis. Inferior axis is lead 2 is 60 degree, lead 3 is 120 degree, AVF is 90 degree as per the axis diagram. Now you see, one is 60, one is AVF is 90, and this all the thing is coming from SA node to AV node. And it is towards the inferior leads. Right? And it is towards, from here, it reaches this thing. So now you are seeing lead 1. So whenever the impulse is coming from the SA node to lead 1, it is positive. Whenever there is going to be a impulses from SA node to the AV node, you are seeing the 2,3 AVF. It is towards the electrode, so it is positive. Simple. So it takes from this area, from SA node to AV node, to reach this SA node to AV node, it takes 0.07 seconds, less than 2 small squares. Whereas in case of patient having, say, right atrial enlargement. So it means that right atrium has enlarged like this. So SA node is located here now. And it takes longer time to come to the AV node. Now then right atrial enlargement happens. So SA node to reach from the impulses to the SA node towards this point, it takes longer time. So longer time means lead to, you see the P wave. It takes longer time, and it is because it travels for a long time, you will see a changes in the lead 2 and to lead for the matter in 3 AVF also. Lead to is the predominantly. Similarly, when there is going to be a left atrial enlargement, see the left atrium is enlarged like this. When it is enlarged like this, see here, from this impulse to reach this area, it takes longer duration. Now you understand? See here, it travels from SA node to AV node, it travels longer length, longer time. From SA node to this left atrial enlargement takes wider. Right? 2 points. Now I will get why it is happening. Now you see the left atrial enlargement from SA node to SA node to figure SA node to AV left atrium, completely it travels for a longer time. Instead of 2 small squares, less than 2 small squares, from this beginning to this area, since it travels for a longer time, it becomes 3 small squares. Right? It becomes 3 small squares. It is wider. Left atrial enlargement is wider because it travels longer time. And this is what it will appear in lead to. The same thing will appear in V1 as a terminal negativity. See here, terminal negativity, the extra length which is being there is there in the terminal. First part is right atrium in V1. Second part is left atrium in V2. And the terminal negativity itself is much longer. It takes more than 40 milliseconds. So now you understand how do you measure left atrial enlargement, right atrial enlargement. Usually it is less than 2 small squares. With in lead 2, if you are seeing more than the 3 small squares, that means you are having left atrial width is wider, this left atrial enlargement. Whereas in V1, if it is biphasic and the terminal is more than 1 small square, you call it as left atrial enlargement. Now you understand why left atrial enlargement happens. And see, this is what the reason. From SA node, it takes a longer time to reach the left atrium. Longer time to reach the left. From this area, it reaches the longer time. This longer duration is the one which we call it as wide left atrial. In lead 2, you are having a wide P wave. In V1, biphasic, the terminal negativity is more than what is 1 small square. Now you understand left atrial enlargement. Similarly, right atrial enlargement, now you see something different. In lead 2, generally I told, it should be more, for that one or 2 small squares should be there. Here, you are seeing more than 3 small squares. More than 3 small squares is there. It means it is not normal. The height is higher. Why the height is higher? Because it travels from this length to this length. This is the height. So when it reaches this height, whatever is recording here, towards the electrode, so it is positive and takes a longer duration, travels longer time. So this traveling of longer time is measured as a height in lead 2. Because lead 2 is positive towards the electrode, it is positive. Now you understand why it is positive. In lead 2, why it is taller. So left atrial enlargement is more wider, right atrial enlargement is taller. So anything more than 2, wider more than 2, height more than 2 small square, think of wide left atrial enlargement, height right atrial enlargement. V1 terminal negativity more than 1 small square, negative QRS negative P wave, think of left atrial enlargement. Now you understand the P wave. All P wave should, QRS complex should precede P wave. And for that matter, P wave should be followed by QRS complex. 2 things should be there. And P wave, when it is traveling for a longer time, it is left atrial enlargement. It is traveling higher, it is right atrial enlargement. Simple. So left atrial and right atrial enlargement is over. So now, either this P wave present or absent. We will see where are the conditions and later on. We will see the basic P wave, how it forms, how this is happening. So next is PR interval. So PR interval segment comprises from beginning of P wave to the QRS complex. The P wave constitutes only the atrial innervation, depolarization. And the repolarization of P wave happens in this QRS complex, which is submerged, and we do not see the atrial relaxation in the ECG. In the AV PR segment, this between the finishing of P wave and the beginning of QRS complex, you have a speed breaker in the AV node. This is for filling of the ventricles, and thereby ventricle is ready for the depolarization. So this is the PR interval from the beginning of P wave to the beginning of QRS complex, the PR interval. Now you understand? So P wave, from this beginning of this P wave to the SA node to the completion in the AV node, and you're getting exited into the bundle of His is the PR interval. Now you understand the PR interval. So this is how you are a P and PR. So as I told you, in the picture itself, it is clearly seen. From this to the bundle of His and right bundle, it takes 0.16. That is 160 millisecond. That is 4 small squares. So that is the reason why the duration is between 120 to 200 milliseconds. That is 3 and 5 small squares. So this is what the PR interval is observed. If the PR interval is shorter, means either it is QRS complex is becoming wider and makes the thing shorter. So pre-excitation, if it is some axillary pathway and pre-excitation happened, the QRS complex becomes wider. That is, beginning itself is wider. That may make the QRS PR interval shorter. Or some AV junctional rhythm will appear very short because it is very close to the, which I will tell you with the example. Sometimes PR interval may be longer. When the AV node is diseased, what happens? The speed breaker is worsens and takes longer time to travel. So that is the reason why PR interval is longer. You call it this as first degree AV block, right? There can be further prolonging, and that can be second degree and third degree AV block, which we can see later on. So I told you, when the QRS complex generally starts from here, there is no initial, see here, there is slur. If it is not there, it will be beginning from this area. So it will be normal. Because the QRS complex, there is initial slur is occupying the PR segment, the PR interval is shorter, less than 120 millis, less than 3 small square, less than 120 millisecond. And this results in widened QRS complex. And this is what is the pre-excitation, and we see it in the WBW syndrome, right? So the other extreme is short PR interval. There are certain situations where the PR interval is much shorter, which is much rarer, but this can also result in a lot of arrhythmias. The PR interval is shorter because when it is shorter, it means the speed breaker is not working. So ventricle filling is not there going to be proper, and the patient is going to have some problem relating to this also. And the patient is not, there will be collision of electrical activity, and there will be a lot of arrhythmias. So short PR interval is also not good. So short PR interval is also present. So I told you about the junctional rhythm, short PR interval. Why this happens? So to understand why this is happening, simple. So when there is a junctional rhythm is happening in this area, what will happen? When this area is the one which is going to give the rhythm, SA node is not functioning. So not functioning means, so this area is taking charge. So from this area, when the P wave is arising, that is the pacemaker activity, to reach this area, it takes only a minuscule time. So what will happen to the PR interval? It is very shorter because it need not travel from SA node to AV node. So whenever there is going to be a pacemaker activity from this area, P wave will be shorter. Now you understand why junctional rhythm, AV nodal rhythm will be much shorter. Here, see here, it is much shorter. So that is the reason why it is shorter. So long PR interval, prolonged PR interval, AV node is diseased. It is not conducting properly. It is conducting with a delay. So long PR interval. Now you forget about second degree, third degree. Now you always think about the basic. When it is PR is prolonged, you know AV node is diseased. When it is not conducting, see here, it is prolonged. Sometimes some beats is missing. P wave is there. There is no QRS now. It is not missing. So I mean this AV node is not able to conduct. So it is diseased further. So that's the reason why you got to follow every P wave is followed by a QRS complex. If it is not there, AV node is diseased. So as simple as that. So moving to the next segment, PR segment. So PR segment can be elevated or depressed. So when it is elevated or depressed, only two conditions. One is when the atrial infarct happens along with the LCX territory infarct or in the RCA territory infarct, there may be branches which supplies the atrium. That atrium can be infarcted as well. Because it is thin, it will not have a tall ST elevation. It's a small ST elevation. See here, PR can be elevated here. See here, PR segment may be elevated or depressed. So it can be there in pericarditis and in ischemia. So this is the way. It is a subtle change. Why? How I am saying is PR is elevated. I can see in my eyes it is elevation, but you cannot see. Means as simple as this. See here, the TP junction. This is the T wave. This is the T wave. End of T, the junction to the next P wave. This is the bottom isoelectric line. So it continues like this. This is the isoelectric line. When it is PR segment is more above this, you call it as elevation. Below this, you call it as depression. See here, it is PR is depressed. In this segment, PR is elevated. It happens in ischemia and pericarditis. So it correlates with the QRS complex. So these changes are very subtle. Even if you are missing it, do not worry. It correlates with the QRS complex. And if your eyes are tuned for it, after you're reading the QRS complex, come back to the PR segment, you will find it. And you will, once you are tuned for it, you will make it a habit for you. So next to going to the important wave, Q wave, QRS complex. So I am just putting it very simple. Normal Q wave, less than 1 millimeter wide. See, I'm carrying a message in cardiology, some conceptual understanding. Here, normal Q wave less than 1 millimeter wide. That means one small square width less than that is normal Q wave. Even if the Q wave is present, it is normal. Except in some leads, but it is normal. And the depth is less than 2 millimeter in depth is normal. More than 2 millimeter only, more than 1 millimeter width, more than 2 millimeter depth, this is normal. That is abnormal, but less than that is normal. So now you find that carry on message very simple. Not every Q wave, whatever you see is abnormal. Small, minuscule, 1 millimeter, less than 1 wide and less than 2 millimeter depth is always abnormal. Normal. Only thing more than 1 millimeter, more than 2 millimeter in depth is abnormal. So carry your message is very clear. So whenever that is pathological, when it is pathological, when it is more than 2 millimeter in wide, 1 millimeter wide, it is pathological. See here, more than 1 millimeter wide, it is pathological. More than 2 millimeter depth, it is pathological. When compared to the QRS complex, more than 20% of the depth, it is pathological. So in the QRS complex, only 4 millimeter total height of the QR wave, and it is 20. If the P wave is less than 1 millimeter, means it is abnormal. So more than 20% of the QRS complex, it is abnormal. Seen in lead V1, V2, V3. V1, V2, V3 will never have P wave, Q wave. It is only R wave. I'll say why it is happening. If it is present in V1, V2, V3, Q wave present is always abnormal, right? So this slide is straight away for memorizing. Straight away memorizing. So what are the possibilities? When the patient is presence of Q wave, always says already an infarct myocardium has happened, some cardiomyopathies will be there, right? So we'll see what is the Q wave. See here the pathological Q wave. It is 1, 2, 3, 3.5 small squares in depth. So it is straight away abnormal. Width is more than 1.5 small square is there. More than one small square in width. So now you are abnormal. It is more than 1 small square width, more than 2 small square in depth, abnormal. Now you see the abnormal pathological Q wave. Now you should, when it is very small, minuscule, forget about it. It is not abnormal. So Q wave, you know, when it is normal, when it is abnormal. R wave. Now this is the most important and you have to understand it completely. Normal transition occurs. Transition means from the QRS complex, it rises and from there you have a starting of S wave. So transition point is V3 to V4. I'll tell you with a diagram. Abnormal R wave. There should not be R wave in AVR. I told you AVR is from the right side. It will be from the right side. If you look into the heart, it is always negative because every wave is away from the your electrical electrode. So it's all the waves will be negative. When there is going to be a positive dominant R in AVR, it is abnormal. Similarly, AVR and V1 is close. V1 is on the right side. You place the lead, it is on the right side. So it is like a AVR, but it is closer to the heart V1. So it is right side. So now, if dominant R in V1, dominant R in AVR, then you have to think something is abnormal. And generally, R wave should gradually increase from V1 to V4. If it is not there and it is not raising the height more than 2 or 3 millimeter, then we call it as poor R wave progression. I'll show you how. So now all the electrodes towards the electrode is positive. Closer to the electrode, height of the complex will be taller. Simple. The two basics. So I am placing the lead right over the heart. V1, V2, V3. See here, V1. You are placing it from outside, but I am trying to place it in the over the heart. It is like V1 will be like here. V2, this is the right ventricle, left ventricle. V2, just interventricular, over the interventricular septum. V3, between this V4 and V3, V2, and V4 at the apex. See now, V1, V2, V3, V4, V5, just lateral to the apex, and V6 lateral to it. Right? Now, see here, second carry home message. The electrical activity comes from above downwards, bundle of his left bundle, right bundle. Our ventricles are, left ventricle is always the dominant ventricle. So left ventricle is the first to be innervated. So dominant to the less dominant right ventricle. So from innervation occurs from top to bottom, and the septal innervation, interventricular septal innervation occurs from left to right. 2 points. Top to bottom and left to right. Right? Now I am putting the lead here. V1, V2, V3. So from V1, I am recording the ECG. I am recording the ECG from V1. So I am recording the ECG. See here, V1 ECG. I am recording it. Electrical activity, I am seeing first electrical activity from this area. I am seeing it. First, left to right, it is a small electrical activity. See here, small. And from the electric activity goes towards travels a longer time and reaches the apex. See here, I am drawing the QRS complex for you. Small r, big S. Right? Now, I am seeing from the V2. From the V2, from top to bottom towards the electrode, see here the height of R wave increases. This is the transition. And from here, see here, the V5, V6, it has to travel from this distance towards this distance. It will be like this. And V3, it is traveling towards the electrode. So travel distance is longer. So it is much higher. As the higher increases and as it goes closer to the apex, the depth of S wave decreases. V4, height of QRS complex further increases and it is closer, there hardly any S wave. In V5, since the first electrical activity from the left to right happens here, it senses the first electrical activity, a small q, and all the waves are much taller. See here, it is much taller. Right? In V6, because it is already going to the lateral side, the height of R wave will be much smaller. Now you understand progression of R wave from V1 to V6, how it gradually increases. Because V1 from V2, it is very close. So it is having the, from V2, it is looking, the impulse has to cross V2 and come to the V5, V6. So it travels away from the electrode. So from the electrode, from V2, it travels away. So it is terminal negativity. So V2 will have small positivity and a terminal negativity. V3, because from here, it has to travel this long. So bundle of His to this area, it is much taller. V3 will be like this. S wave will be shorter. V4, it is in the apex. The height of R wave increases, whereas the depth of S wave decreases. V5, it is the top. Begin with the first electrical activity will be negative, and the rest of the activity will be positive. Now you see the progression of R wave, and there will be a regression of S wave. The QRS complex height will be total, will be the same. You measure from V1 to V5, height of the total duration of QRS complex, Q, R and S wave, if you measure, it will be the same. Only thing, R wave is progressing and similarly S wave is regressing. Now you understand how Y is our progression, what is progression of R wave, what is regression of S wave. When it is not happening, then it is. So to begin with, there is V1, V2, if there is, begin with, there is a negative activity, Q wave, then it is always abnormal because Q wave cannot happen. So now having known that how it progresses, how it regresses, see here, V1, there is a small V1, small positivity, rest all it is negative, so it is longest. V2, see here, the height of R wave increases and the depth of S wave will slowly decrease. V3, it is further increasing. Similarly, the height of S wave, depth of S wave decreases. R wave, for V4, it is slow, largely increased, and you are seeing a terminal small S wave. Whereas in the V5 and V6, you see a small, to begin with, a small negativity. The small negativity is the left-right conduction in the IVR, intraventricular septum. This is how the QRS complex progression happens. See here, it's a normal sinus rhythm. I'll tell you, upright P wave in lead 1, inverted P wave in AVR. Every P wave is followed by a QRS complex. PP interval is constant. RR interval is constant. And you are seeing it as a sinus rhythm. R wave progression is happening. S wave regression is happening. And you are having a perfectly normal looking ECG. Now you know how you are going to read. Every ECG you got to read in this way. Then only you will find the ECG reading easy. So when it is taller, when AVR, everything is negative. When it is taller means, so it means that dextrocardia, opposite is happening. Instead of going from left to right, opposite is happening. Dextrocardia, right? Towards the heart is on the right side, all electric towards the right side. It means towards AVR, it is going to be positive. So when you change the left to right arm, that is most common dominant R wave, because the mistake by the technician, it will be positive. So whenever there is a positive AVR, do not panic. It is most of the time lead change reversal has happened. Sometimes dextrocardia may be there. Very rarely you find the poisoning and ECG. And when ventricular tachycardia, you will find, I will tell you when it comes to ventricular tachycardia, I will teach you why it is positive. And similarly, when the R wave is dominant in V1, I told you, it's a minuscule R wave because it is very small and rest of the ECG has to, electrical activity has to travel long time towards the apex. So it should be very small. When it is there means, so activity on the right side is stronger. Right means right ventricular hypertrophy, right bundle branch block, posterior MI, WPW syndrome type A. HCM Sampa, dextrocardia. So these are the common conditions where you have a dominant R wave in V1. So when it is not progressing properly, I told you it has to progress properly from V1 to V5. If it is not progressing properly, there should not be electrical activity. That means old anterior LMI, it should not progress. QS pattern is there. When the left ventricular hypertrophy is taking taller, it means the ventricle is slightly altered in configuration and there will be non-progression. In case of cardiomyopathy, there may be non-progression. Obviously, anything happening, whether we have to see whether the lead has changed or not. So this is this is what we normally look into poor RWave progression. I told you when you call poor RWave progression, when it is high progression is not happening, height of R wave is less than 3 millimeter in V3, V2, V3. Then it is called poor progression. So most of the time is abnormal. Sometimes it may happen in isolated left anterior fascicular block. It may happen as a normal phenomenon. In left ventricular hypertrophy without any pathology, it may happen. With left axis deviation, it may happen in a left ventricular hypertrophy. So rest all are will be abnormal. Try and find the abnormality. Now we'll see that once we have seen how progression of RA happens, why QA, but what is pathological QA, what is normal QA. Now you have seen until this. What will be the QRS complex duration? Generally, here again, the QRS complex, most of the time it is less than 2 small squares. So P wave is less than 2 small squares. QRS complex is most of the time 2 small squares. PR interval, that is AV nodal part also is around 2 to 3 small squares. Now you see 2 small square. Why I am sorry? Yeah, around 80 milliseconds, the area where most of the QRS duration is happening. So duration usually 80 milliseconds. Up to 100 milliseconds can be there. Narrow QRS. If it is wider means either a pre-existing bundle branch block, a right bundle branch block, left bundle branch is there, or the patient is having ventricular rhythm. That's all. Wider means only two. Pre-existing block, bundle branch block is there, or the impulse is coming from the ventricles. It is not from the SA node. As simple as that. If it is from the SA node, that should be bundle branch block. So which I will describe it later. So whenever there is a QRS complex is high. So now you saw, say whenever the LVH is there. So when there is a LVH is happening. So left ventricle is thickened like this. So the QRS complex from endocardium to epicardium has to travel a longer time. So generally the height of R wave in V5 is say 15 millimeter. 15 millimeter means when it travels longer time, it will be 25 millimeter. So that means that the patient is having left ventricular hypertrophy. Now we understand the longer the time traveling, it causes more height of R wave. So left ventricular hypertrophy, you have it as height of R wave is much taller, right? So height of R wave is much taller. Low voltage is whenever the thick chest wall is there. So it is electric activity is not able closer to the heart, it is taller. Thick chest wall, pleural effusion, fluid in between. You will find small voltage complex. That's all, pericardial effusion, small voltage complex. So simple. See, the basics are basics. Once you understand the basic, it becomes very, very simple. Okay. Anything conduction abnormality, it is not conducting. Liquid is not conducting, pericardial effusion, pleural effusion. And you are not thick chest wall. Your muscle and fat is not able to conduct. You will have small voltage complex. That's all. Simple. High voltage, longer duration to travel. Left ventricular hypertrophy. Simple. So whenever there is going to be a widened QRS complex, it could be RBB or LAFB. Sometimes from the ventricular complex, which we'll see as we go, as we increase our knowledge. Right now, I have completed the basic of P wave, PR interval, QRS complex. Until now, I'll just unmute everybody. Whoever is willing to. So whoever is willing can unmute yourself and ask the question.
Are both left and right atrium enlargement in this situation? How it will be, sir? Both left and right and atrial enlargement.
Whoever wants to discuss something, you can unmute and discuss. Hey, you can unmute yourself. I have unmuted here.
Sir, I am Dr. Damodaran.
Is there any doubt? Somebody has unmuted themselves. You can discuss regarding the class, whatever is there.
விடுதலை போராட்டத்திற்காக வந்து வந்ததுக்கு அப்புறம் இந்த இரண்டுக்குமான எப்படி ஆசிரியர் அவரும் பதினேழு வயதிலே அரசு சமூக நீதி, சம உரிமை, சம நீதி. அப்ப இந்த சமூக விடுதலை ஒழுங்குபடுத்த இயக்கம் அமைப்பதற்கு நீதி நாடு திருமுனை கூட்டத்தில், அதாவது ஐக்கிய கிழக்கு திட்டமா சொல்றாங்க வைத்துக் கொண்டு அவர் கிராமங்கள்ல போய் நீதி நாடகம் சமூக விழிப்புணர்வு ஏற்படுத்தியிருக்கிறாங்க. நாம் வந்து யாருக்கும் கால் பண்ணல, நாம் வந்து ஐடென்டி கிடக்கல.
Since no questions are there, and I think we should end this session. And next week we'll see the ST segment, why it is getting elevated, why it is getting depressed, and T wave. So that means that the PQRST will be over, and from there on we'll proceed for the detailed discussion about the pathological condition. From basics we'll slowly move to the pathological condition. And here there's somebody who has recorded the ECG this session. Please try and put it in the ECG forum for everybody's benefit. Thank you very much. We will close the session then.
அப்ப இறைவனுக்கு